Good day. Today we are discussing burns. Although overall survival for thermal burns exceeds 96%, fire, burn, and smoke inhalation still account for approximately 3,400 deaths each year in the United States. Elderly patients understandably have a disproportionately higher death rate. The risk of death from a major burn increases with larger burn size, older age, the presence of inhalation injury, and female gender. The Centers for Disease Control and Prevention lists the following groups at being at an increased risk for fire-related injuries and death: children younger than or at 4 years of age, adults older than or at 65 years of age, African Americans and Native Americans in the United States setting, persons living in rural areas, persons living in manufactured homes or substandard housing, and persons living in poverty. Care of the acute burn injured patient has improved significantly over the last several decades. The rate of hospital admissions has decreased owing to improvements in both acute care provided in the emergency room and outpatient care at specialized burn centers. Only approximately 4% of those treated in specialized burn treatment centers die of their injuries or associated complications. Skin consists of two layers: the epidermis and the dermis. Skin thickness varies both by age and anatomic location. It is relatively thinner at extremes of age, whereas it is thicker on the palms, soles, and upper back. Thus, the depth and severity of thermal injury varies by both age of the victim and the anatomic location exposed. Skin functions as a semi-permeable barrier to evaporative water loss, protects against environmental assault, and aids in the control of body temperature, sensation, and excretion. Partial thickness thermal injury disrupts these barrier functions and contributes to free water deficits. This effect may be significant with moderate to large burns. Thermal injury results in a spectrum of local and systemic homeostatic disorders that contribute to burn shock. These include disruption of normal cell membrane function, hormonal alterations, acid-base disturbances, hemodynamic changes, and hematologic derangement. The fluid and electrolyte abnormalities seen in burn shock are largely the result of alterations of cell membrane potential, causing intracellular influx of water and sodium and extracellular migration of potassium secondary to dysfunction of the sodium pump. In patients with burns greater than 60% of total body surface area, depression of cardiac output results in a lack of response to aggressive volume resuscitation. Although disputed by others, Baxter and Shires have explained this phenomenon on the basis of circulating myocardial depressants. Systemic vascular resistance is increased. A significant metabolic acidosis may be present even in the early stages of a large burn injury. Massive thermal injury results in an increase in hematocrit with increased blood viscosity during the early phase, followed by anemia from erythrocyte extravasation and destruction. Surprisingly, however, transfusion is seldom required for patients with isolated burn injury, and aggressive transfusion has been associated with an increase in morbidity and mortality. The physiologic effects of thermal injury include the disruption of sodium pump, intracellular influx of sodium and water, extracellular efflux of potassium, depression of myocardial contractility when there is more than 60% of the body surface area burned, increased systemic vascular resistance, metabolic acidosis, increases in hematocrit and increased blood viscosity, secondary anemia from erythrocyte extravasation and destruction, local tissue injury, and release of histamines, kinins, serotonins, arachidonic acids, and free oxygen radicals. Thermal injury is progressive. Local effects of thermal injury include the liberation of vasoactive substances, disruption of cellular function, and the formation of edema. The subsequent systemic response alters the neurohormonal axis and further extends the injury. Implicated in these events are histamine, kinin, serotonin, arachidonic acid metabolites, and free oxygen radicals. These substances exert their primary effects at the local level and cause progression of the burn wound. Although many factors may influence prognosis, the severity of the burn, the presence of inhalation injury, associated injuries, the patient's age, comorbid conditions, and acute organ system failure are most important. Cell damage occurs at temperatures of greater than 45 degrees Celsius owing to denaturation of cellular protein. The size and depth of the resulting burn are functions of the burning agent, its temperature, and the duration of exposure. Burn wounds are described as having three zones: the zone of coagulation, in which tissue is irreversibly destroyed with thrombosis of blood vessels; the zone of stasis, in which there is stagnation of the microcirculation; and the zone of hyperemia, in which there is increased blood flow. The zone of stasis can become progressively more hypoxemic and ischemic if resuscitation is not adequate. In the zone of hyperemia, there is minimal damage to the cells and spontaneous recovery is likely. The size of a burn injury is quantified as the percentage of body surface area involved. The rule of nines is a simple and commonly used method to calculate burn size. It divides the body into segments that are approximately 9% or multiples of 9%, with the perineum forming the remaining 1%. Because of the proportionately larger heads and smaller legs of infants and children, this method must be modified in pediatric burn injury. So, when it comes to the relative percentage of areas affected by growth based on age and years, for the half of the head in infants, it's 9.5. For 1 year olds, it's 8.5. For 5 years old, it's 6.5. For 10-year-old patients, it's 5.5. For 15-year-old patients, it's 4.5. And for adults, it's 3.5. For half of the thigh, in infants, it's 2 and 3/4. For 1 year olds, it's 3 and 1/4. For 5 year olds, it's 4. For 10-year-olds, it's 4 and 1/4. For 15-year-olds, it's 4.5. And for adults, it's 4 and 3/4. And for half of the leg, for those who are infants, it's 2.5. For 1 year olds, it's 2.5. For 5 year olds, it's 2 and 3/4. For 10-year-olds, it's 3. For 15-year-olds, it's 3 and 1/4. And for adults, it's 3.5. So basically, the forearm is 2% each, and the rest of the arm is 1.5% each, and each hand is 1.5. The torso is 13, whether it's the back or the front. As mentioned earlier, the perineum is 1%. Each of the buttocks are 2.5%, and each foot is 1 and 3/4. So the head on an adult is 9%. Both arms is 9% each, like the entire arm, including the hand, and both legs, including the thigh, are 18%. A second method assumes that the area of the back of the patient's hand is approximately 1% of their total body surface area. The number of hands that equal the area of the burn can approximate the percentage of body surface area burned. A third and more precise method uses the Lund-Browder burn diagram. This allows an accurate age-adjusted determination of burn size for a given depth, allowing for the anatomical differences of children. Experienced burn care nurses and physicians can reliably estimate burn size regardless of the method used. Although it is common for inexperienced individuals to estimate burn size incorrectly when patients are first assessed in the emergency room, it remains a vital determinant of both fluid resuscitation and the need for ultimate transfer. So, burn depth features can be classified by the degree of the burn. For superficial or first degree burns, it involves the epidermis, there are no blisters, and it's painful. An example is sunburn, and healing is usually within a week. Superficial partial thickness burns are superficial second degree burns. They involve the epidermis and superficial dermis. Blisters can be formed and they're very painful. An example is hot water scalding. There is healing within 14 to 21 days with no scarification. For deep partial thickness or deep second degree burns, it involves the epidermis and deep dermis, sweat glands, and hair follicles. Blisters may occur and they're very painful. Examples are hot liquids, steam, grease, and flames. Healing occurs in 3 to 8 weeks with a permanent scar. Full thickness or third degree burns involves the entire epidermis and dermis being charred. It is pale, leathery, and there is no pain due to the destruction of the nerve endings. An example is flame. Healing can take months with severe scarring, and skin grafts are necessary. Fourth degree burns are like third degree burns except bone, fat, and or muscle are also involved in the burn. So flame can also cause this, and healing also takes months, and multiple surgeries are usually required. The depth of a burn has been historically described in degrees, as mentioned earlier. However, a classification of burn depth, according to the need for surgical intervention, has become the accepted approach in burn treatment centers: superficial partial thickness, deep partial thickness, and full thickness burns. Determination of burn depth requires clinician judgment using commonly observed wound features. There is no objective method of measuring burn depth, and burn wound biopsy is not routine practice. Like mentioned earlier, a superficial burn involves only the epidermal layer of skin. Sunburn is frequently given as an example, even though it is caused by ultraviolet light instead of thermal injury. The burned skin is red, painful, and tender without blister formation. Partial thickness burns extend into the dermis and are subdivided into superficial partial thickness and deep partial thickness burns. In superficial partial thickness burns, the epidermis and the superficial dermis in the papillary layer are injured, while the deeper layers of the dermis, hair follicles, and sweat and sebaceous glands are spared. Superficial partial thickness burns are often caused by hot water scalding. The skin is blistered and the exposed dermis is red and moist. These wounds are exceedingly painful to touch. The dermis is well perfused with intact capillary refill. Healing typically occurs in 14 to 21 days. Scarring is usually minimal and there's full return of function. Deep partial thickness burns extend into the deep dermis or the reticular layer, compared to superficial partial thickness where only the papillary layer is involved. Hair follicles and sweat and sebaceous glands are damaged, but their deeper portions usually survive. The skin may be blistered and the exposed dermis is pale to yellow in color. The burned area does not blanch. It has absent capillary refill and absent pain sensation. So when it comes to burn depth features to the American Burn Association burn classification guidelines, a burn is a major burn if its partial thickness greater than 25% body surface area with an age of 10 to 50 years old, partial thickness for more than 20% body surface area in ages less than 10 years old or older than 50 years old, and full thickness greater than 10% body surface area in anyone. Burns involving the hands, face, feet, or perineum, burns crossing major joints, circumferential burns of an extremity, burns complicated by inhalation injury, electrical burns, burns complicated by fracture or other trauma, burns in high risk patients are all major burns, and you dispose of them in the burn center for treatment. Moderate burns are partial thickness 15 to 25% body surface area in ages 10 to 50 years old, partial thickness of 10 to 20% body surface area in ages less than 10 years old or more than 50 years old, and full thickness burns less than or equal to 10% body surface area in anyone with no major burn characteristics present. You just hospitalize these patients. And for minor burns, these are patients with a partial thickness burn of less than 15% body surface area in ages 10 to 50 years old, partial thickness burns of less than 10% body surface area in ages less than 10 years old and older than 50 years old, full thickness burns of less than 2% in anyone, and no major burn characteristics present. These all involve outpatient treatment. When it comes to the American Burn Association burn unit referral criteria, these are full thickness or third degree burns in any age group. These include electrical burns, including lightning injury, chemical burns, inhalation injury, burn injury in patients with pre existing medical disorders that could complicate management, prolong recovery, or affect mortality, burn injury in any patients with concomitant trauma such as fractures in whom the burn injury poses the greatest risk of morbidity or mortality, burn injury in children in hospitals without qualified personnel or equipment to care for children, burn injury in patients who will require special social, emotional, or long-term rehabilitative intervention, and burn injury in children less than 10 years old and adults older than 50 years old of age. Because all dermal elements in third degree burns are destroyed, these injuries do not heal spontaneously. Surgical repair and skin grafting are necessary, and significant scarring is the norm. Fourth degree burns, which I described earlier, are devastating and life threatening, so amputation or extensive reconstruction is sometimes required. As treatment of burn shock and sepsis has improved, inhalation injury has become the main cause of mortality in burn patients. Most fire-related deaths are due to smoke inhalation. Inhalation injury is also associated with closed space fires and conditions that decrease mentation, such as overdose, alcohol intoxication, drug abuse, and head injury. Exposure to smoke includes exposure to heat, particulate matter, and toxic gases. Direct thermal injury is usually limited to the upper airway, and thermal injuries below the level of the vocal cords can occur in cases of steam inhalation. Smoke contains particulate matter, usually less than zero point 0.5 micrometers in size, which is formed from incomplete combustion of organic material, and this usually produces carbon monoxide. Small particles may reach the terminal bronchioles where they can initiate an inflammatory reaction that leads to bronchospasm and edema. Toxic inhalants are divided into three large groups: tissue asphyxiants, pulmonary irritants, and systemic toxins. The two major tissue asphyxiants are carbon monoxide and hydrogen cyanide. So, carbon monoxide poisoning is a well known consequence of smoke inhalation injury. Severe carbon monoxide poisoning produces brain hypoxia and coma. Comatose patients lose airway protective mechanisms, which may result in aspiration and further pulmonary injury. All patients with suspected carbon monoxide exposure should receive 100% oxygen by non-rebreather mask and should be evaluated for hyperbaric oxygen therapy. Hydrogen cyanide is formed by the combustion of nitrogen-containing polymers such as wool, silk, polyurethane, and vinyl. Cyanide binds to and uncouples mitochondrial oxidative phosphorylation, which leads to profound tissue hypoxia. Inhalation injury damages endothelial cells, produces mucosal edema of the small airways, and decreases alveolar surfactant activity, resulting in bronchospasm, airflow obstruction, and atelectasis. Bronchospasm may occur early. Although lower airway edema may not be clinically evident for up to 24 hours, upper airway edema can occur rapidly. Over time, tracheal and bronchial epithelial slowing occurs. Approximately half of intubated burn patients admitted to burn centers develop acute respiratory distress syndrome. Therefore, when inhalation injury is present, careful fluid resuscitation guided by hemodynamic monitoring can help avoid pulmonary edema and acute respiratory distress syndrome. The initial diagnosis of smoke inhalation is made from a history of exposure to fire in an enclosed space and physical signs that include facial burns, singed nasal hair, soot in the mouth or nose, hoarseness, carbonaceous sputum, and expiratory wheezing. No single method for diagnosing the extent of inhalation injury exists. Measurement of arterial carboxyhemoglobin is used to document prolonged exposure to products of incomplete combustion. The chest radiograph may be normal initially. Bronchoscopy and radionuclide scanning may also be helpful in evaluating the full extent of injury. We treat suspected inhalation injury prior to definitive diagnosis. Provide humidified oxygen at 100% by face mask. Obtain arterial blood gases, including carboxyhemoglobin levels. Control of the upper airway is achieved by prompt endotracheal intubation. Indications include full thickness burns of the face or perioral region, circumferential neck burns, acute respiratory distress, progressive hoarseness or air hunger, respiratory depression or altered mental status, and supraglottic edema and inflammation on bronchoscopy. The management of patients with moderate to major burns can be divided into three phases: pre-hospital care, emergency resuscitation and stabilization, and administration or transfer to a specialized burn center. So, during pre-hospital care of the burn patient, it consists of stopping the burning process, assessment, and if necessary, securing the airway, initiating fluid resuscitation, relief of pain, protecting the burn wound, and transporting the patient to an appropriate facility. On-site assessment of a burn patient is divided into primary and secondary surveys. Primary survey, of course, is identification and treatment of immediately life-threatening conditions. So, you treat burn injured patients similar to other trauma patients: airway, breathing, circulation, and cervical spine immobilization where appropriate. During the secondary survey, we do a head to toe evaluation. The patient must be removed from the burning environment, and burning clothing must be immediately removed as well. The remainder of the clothing should be removed after the airway, breathing, and circulation are secured. We remove rings, watches, jewelry, and belts because they can retain heat and produce a tourniquet like effect on the extremity, causing ischemia. We pay attention to the airway, Rapid deterioration may occur even when the initial assessment judges the airway to be acceptable. We consider prophylactic intubation in patients with perioral burns sustained in a closed space fire. We give IV isotonic crystalloids and cover the patient with clean sheets to protect the wound. While early cooling can reduce the depth of the burn and reduce pain, uncontrolled cooling may result in hypothermia. We provide analgesia and transport the patient to the nearest emergency room capable of caring for a burn injured patient, or if none is available, to the nearest emergency room for stabilization and subsequent transfer. So, as mentioned earlier, we need to check airway, breathing, and circulation. So, we assess the patient's respiration and circulation and initiate stabilization. And we assess the adequacy of circulation by noting the blood pressure, pulse rate, capillary refill time, mental status, and urinary output. And when we look at the secondary examination, we have to examine the eye for corneal burns. Routine laboratory tests, including a CBC, measurement of electrolytes, BUN, creatinine, and glucose levels, should be performed because of the effects of thermal burns on metabolism in general. And we have to get an ABG and carboxyhemoglobin level, serum creatine kinase, urinalysis for myoglobin, chest radiographs, and EKG for those with moderate or severe burns due to destruction of extensive parts of the skin and extension into the muscles. The burn shock resuscitation formulas in use today are derived from laboratory studies of burn shock and resuscitation, and the utility of such formulas have been called into question. But there is the Parkland formula for fluid resuscitation. In adults, it's LR 4 ml times weight in kilograms times the percentage of body surface area burned over the initial 24 hours. Half of this dose is given over the first 8 hours from the time of burn and the other half over the subsequent 16 hours. So in a 70 kilogram adult with 40% second and third degree burns, it's 4 ml times 70 kilograms times 40. So you give 11,200 ml of LR over 4 hours. LR 3 ml times weight in kilograms times the percentage of body surface area burned over initial 24 hours plus maintenance is the formula for children. So same as with adults, we give half over the first 8 hours from the time of burn and the other half over the subsequent 16 hours. So the difference is just the ml of lactated ringer solution that you give. For adults, it's 4 ml. That's the constant. And for children, the constant is 3 ml. The formulas are just a guide for fluid resuscitation of the burn injured patient, so we have to monitor and adjust them according to individual patient response. Patients with thermal injury and concomitant multi-system trauma and those with inhalation injuries generally require fluid resuscitation in excess of calculated needs. Burn patients with pre-existing cardiac or pulmonary disease require much greater attention to fluid management because of the risk of congestion or heart failure. We monitor fluid resuscitation closely by frequent assessment of vital signs, cerebral and skin perfusion, pulmonary status, and urinary output, as well as hemodynamic monitoring. Urine output should be 0.5 to 1 ml per kilogram per hour. Because the emergency room is primarily responsible for initial fluid resuscitation, discussion with burn specialists may be helpful in avoiding early under or over resuscitation. So, when it comes to emergency care of patients with major burns, we evaluate the airway and perform early intubation for any sign of breathing difficulty, airway burn, swelling, or suspected inhalation injury. For breathing, we do continuous pulse oximetry with supplemental oxygen, determine carboxyhemoglobin levels, bronchoscopy if inhalation injury is a concern, and provide mechanical ventilation as needed. For circulation, we keep the vein open by establishing two large bore peripheral IV lines in unburned skin, and we also administer lactated ringer solution using the Parkland or other burn resuscitation formulae and do cardiac monitoring. Adjuncts include the placement of a Foley catheter, the insertion of a nasogastric tube, tetanus booster, assess for other trauma using advanced trauma life support guidelines, and pain control. In children who weigh less than 25 grams, a goal urine output of 1.0 ml per kilogram per hour is necessary. Add 5% dextrose to maintenance fluids for children weighing less than 20 kilograms due to smaller glycogen stores. Additions or modifications to isotonic crystalloid resuscitation have been studied. These are adjuvant colloid and hypertonic saline. However, neither of these improve patient outcome. Electrical injuries, incineration burns, and associated crush injuries may produce rhabdomyolysis and myoglobinuria, leading to renal failure. Acute renal failure occurs in approximately 15% of patients admitted to burn centers and is associated with severe burns with a mean body surface area involvement of 48%. After evaluation and resuscitating the patient, we attend to burn wounds. Initially, wounds are best covered with a clean, dry sheet. Later, they can be covered with a moist, saline-soaked dressing while the patient is awaiting admission or transfer. The soothing effect of cooling on burns is most likely due to local vasoconstriction. Cooling stabilizes mast cells and reduces histamine release. It also reduces kinin formation and thromboxane B2 formation. For large burns, sterile drapes are preferred because application of saline soaked dressings to a large area can cause hypothermia. Patients with circumferential deep burns of the limbs may develop compromise of the distal circulation, particularly after initiation of resuscitation. The distal vascular status of such patients must be monitored closely, including pulses, capillary refill, pulse oximetry, and skin temperature. Doppler flow testing may likewise be useful. If vascular compromise is evident, escharotomy is indicated. The eschar is incised with a scalpel to the level of the fat on the mid-lateral portion of the limb, using care to avoid incising the fascia. Elevated compartment pressures can be clinically evident. The incision may be extended to the hand and fingers. Escharotomy may provide substantial soft tissue bleeding. If there are circumferential burns of the chest and neck, the eschar may restrict ventilation. An escharotomy of the chest wall should be performed to allow adequate ventilation. Incisions are made at the anterior axillary line from the level of the second rib to the level of the 12th rib. These two incisions should be joined transversely so the chest wall can expand. Burn injuries are exceedingly painful, and superficial partial thickness burns are the most painful. Burn injury not only makes an otherwise already injured area and surrounding tissue more painful, but also causes hyperalgesia, chiefly mediated by A fibers. Local cooling may be soothing, but does not provide pain control and can cause hypothermia, and additional pain management should be provided. During the acute phase, the preferred route for most medication is IV. Opioids are the mainstay of treatment, and relatively large doses may be required. Anxiolytic agents may also be given. We ensure adequate analgesia for patients being discharged, including a regimen for both background and breakthrough pain associated with dressing changes. Achieving adequate pain control is required for patients being considered for discharge. Minor burns, on the other hand, typically qualify for ambulatory care. They should be isolated, should not cross joints, or be circumferential, and should not meet criteria for burn center care. Even in patients with burn injury that is less than 10% of body surface area, patients at the extremes of age and/or patients with significant comorbidities, challenging social situations, or inadequate pain control should be treated as inpatients and possibly be transferred to a burn center. Because burns are painful, again, we provide appropriate analgesia. We debride any ruptured blisters. And we also clean the wound with mild soap and water or dilute antiseptic solution. So, to summarize the emergency care of minor burns, we provide appropriate analgesics before burn care and for outpatient use, cleanse the burn with mild soap and water or dilute antiseptic solution, debride the wound as needed, apply a topical antimicrobial, usually 1% silver sulfathiazine cream, not on the face or in patients with a sulfa allergy, obviously, bacitracin ointment or triple antibiotic ointment, neomycin, polymyxin B, and bacitracin zinc. We also consider the use of synthetic occlusive dressings and provide detailed burn care instructions with follow-up in 24 to 48 hours. So the reason why we give topical antimicrobials is to reduce bacterial colonization and enhance the rate of healing in burns. Dressing should be ideally changed twice daily, gently removing residual ointment for as long as the wounds continue to weep, then daily until healing is complete. Our source is Tintinalli's Emergency Medicine. Thank you.